Hello, KJR readers. Welcome to the Listen to Authors of KJR Online. I'm Dr. Park from Asan Medical Center in Korea. I'm one of the first authors of this study. I'm very happy to have the opportunity to introduce this study to you. Let me start with introducing the background of this study. Liver volume assessment is an important preoperative workup for liver surgery such as hepatectomy and living donor liver transplantation, as the remnant liver volume is a major determinant for postoperative morbidity. Generally, for hepatectomy, the remnant liver volume should be at least 35% of total liver volume, and for liver transplantation, the graft-to-recipient body weight ratio should be higher than 80%. Liver volumetry has been performed by slice-by-slice segmentation on cross-sectional images such as CT and MRI. By using Gadoxetic acid-enhanced MRI, we can assess not only liver volume but liver function. Liver function is reflected on hepatobiliary phase MR images and therefore allows assessment of both liver volume and function. The signal intensity of the liver on hepatobiliary phase images, normalized by spleen signal intensity, has been known to be positively correlated with liver function and therefore enables assessment of functional liver volume. By the way, to measure liver volume using the cross-sectional images, liver segmentation is required. However, slice-by-slice manual liver segmentation is a time-consuming and labor-intensive task. There have been several deep learning algorithms developed for automated liver segmentation, which may dramatically reduce time and labor required for liver segmentation and thus facilitate the clinical use of liver volumetry. Most of them showed very high accuracy, showing the dissimilarity coefficient of higher than 0.9. However, the studies were preliminary and mostly focused only on the technical feasibility. Also, the algorithms were not thoroughly validated, and the clinical utility of functional liver volumetry has not been well investigated. Therefore, we aim to develop and validate a deep learning algorithm for fully automated measurement of volume and signal intensity of the liver and spleen using the Gadoxetic acid-enhanced hepatobiliary phase MR images, and to evaluate the clinical utility of the deep learning assisted functional liver volume assessment. The development dataset was consisted of 1,014 patients who underwent liver resection, liver transplantation, or liver biopsy and preoperative Gadoxetic acid-enhanced liver MRI. 72% was men, and more than half of the patients had hepatitis B, which was the most common etiology of underlying liver disease. Hepatic mass was present in 82% of patients. The liver fibrosis stage was most commonly F0, followed by F4. MR images were obtained from 3 vendors and more than 9 scanners. To develop a deep learning algorithm, we first generated ground truth segmentation map. Then, the hepatobiliary phase images were preprocessed through resizing and z-normalization. After the preprocessing, we developed a deep learning algorithm for segmentation model. We used DeepLab version 3+, a convolutional neural network for liver segmentation. The final model output was the classification of each voxel among the liver, spleen, and the background. This is the overall architecture of our deep learning algorithm. To test the measurement accuracy of the deep learning algorithm, we used data of 200 patients from our institution, Asan Medical Center, and other 2 university hospitals. In the test data set, 110 MRIs were obtained from our institution, and the rest 90 MRIs were obtained from other sites. The characteristics of the test data set were as shown here. MR images of the test data set were obtained from 3 vendors and more than 10 scanners. Next, we have developed a functional liver volume index. First, let me briefly explain the background. The signal of a tissue on a spoiled GRE sequence depends on multiple factors including operator-dependent MRI parameters such as repetition time, echo time, and flip angle, and several intrinsic tissue parameters such as T1, T2 star, and spin density. The liver-to-spleen signal intensity ratio, abbreviated as LSSR, which is a hepatic signal intensity divided by that of spleen on hepatobiliary phase images, has been used as a liver functional metric in previous studies. However, considering the previously mentioned factors influencing MR signal, we now understand that aLSSR is in fact affected by repetition time and flip angle. Therefore, to use liver signal as an index of liver function, this effect should be adjusted. Based on the previous equation, with the given aLSSR, repetition time, and flip angle, T1 of liver and spleen can be calculated. And through multiple computer simulation, we found multiple combinations of T1 of liver and T1 of spleen. Then multiple spleen to liver T1 ratio can also be calculated. This is aLSSR. Then the median value of the multiple values of aLSSR was calculated, which is the final adjusted aLSSR. We have provided a free web calculator for easy acquisition of the adjusted aLSSR. With our deep learning algorithm, we could obtain a standardized liver volume parameter, which was the liver volume divided by body surface area. Also, using our deep learning algorithm, we could obtain the liver function metric, which was adjusted aLSSR. By multiplying these two, we could finally obtain the functional liver volume index. We tested the clinical utility of the calculated functional liver volume index in 276 patients who underwent Gadoxetic acid-enhanced liver MRI and ICG test on the same day. The characteristics of the patients were as follows, and one MRI vendor was used to obtain liver MRI for this group. To assess the performance of the deep learning algorithm for segmentation and signal intensity measurement, the results of the algorithm was compared with those of the ground truth. The segmentation performance was analyzed using the dissimilarity coefficient, and the agreement between the deep learning algorithm and the ground truth for volume and signal intensity measurement was evaluated using the Blend-Altman analysis. The feasibility of functional liver volume index in correcting for the effects of the MRI parameters on aLSSR was evaluated by correlation between not adjusted aLSSRs and the correlation between adjusted aLSSRs by linear regression analysis. The clinical feasibility of the deep learning assisted functional liver volume index was validated in two ways. First, the correlation between the deep learning algorithm assisted functional liver volume index and ICG test was evaluated by Pearson correlation coefficient, and the diagnostic performance of the MRI derived index to predict decreased liver function was evaluated using ROC analysis. ICG retention rate at 15 minutes equal or greater than 20% is usually considered as an impaired liver function and as a contraindication for major hepatectomy. This criteria was used to indicate decreased liver function in this study. The mean dissimilarity coefficient of liver segmentation was 0.98 and that of spleen segmentation was 0.95, suggesting very high accuracy. The segmentation performance of the algorithm was not different between the internal and external test data and between different MRI field strength. Segmentation performance of the liver did not differ according to the fibrosis stage, while the segmentation performance of the spleen was different. The segmentation performance was not different according to the liver function. So, in overall, deep learning algorithm showed high accuracy in both liver and spleen segmentation and was not influenced by MRI acquisition site, MRI field strength, fibrosis stage, and liver function. These graphs show the blend Altman analysis between the ground truth and deep learning algorithm. The liver and spleen volume calculated by the deep learning assisted segmentation map showed no significant bias. Regarding the signal intensity, no bias was found for any of the signal intensity indices measured by the deep learning algorithm. Therefore, deep learning algorithm showed good agreement with ground truth in both volume and signal intensity measurement of the liver and spleen. The ground truth and the segmentation maps produced by the deep learning algorithm showed good agreement with a very small segmentation difference even in the patients with liver mass or liver cirrhosis. In patients who underwent 2 sets of MRI using different MRI parameters, as shown in these scatter plots, the LSSRs measured on flip angle of 19 degrees images were overestimated compared with those measured on the flip angle of 10-degree images, with a regression slope of 1.52 and an intercept of 0.38. However, the use of adjusted LSSR resulted in very similar estimates between the 2 MRI sets, as indicated by a regression slope close to 1 and an intercept close to 0. So, the use of adjusted LSSR resulted in higher consistency between images of different MRI parameters than non-adjusted values. And when the deep learning assisted functional liver volume index was compared with ICG test results, the index showed linear correlation with the ICG test results. The functional liver volume index achieved the area under the curve of 0.938 to predict ICG retention test at 15 minutes equal or higher than 20%. These are the examples showing the deep learning algorithm-assisted functional liver volume index in accordance with ICG test results. All these patients had liver cirrhosis. With the visual inspection of MR images only, it is difficult to assume which patient has the best or the poorest liver function or is contraindicated to major hepatectomy. The deep learning algorithm-assisted functional liver volume index showed that patient A had the highest functional liver capacity, while patient C had the lowest functional liver capacity, which was consistent with the ICG test results. The main findings of the study are: we developed a deep learning algorithm for segmentation and signal intensity measurement of liver and spleen using gadoxetic acid-enhanced hepatobiliary phase MR images. And the algorithm showed excellent and robust performance in both segmentation and signal intensity measurement of liver and spleen. By using this algorithm, we could obtain functional liver volume index, and this index allowed prediction of impaired liver function with high AUC. The study limitations include that our deep learning algorithm only provides information of the whole liver, so that additional intervention is required to assess volume or function of a part of liver. And clinical feasibility of the deep learning assisted functional liver volume index was evaluated using only single MRI vendor, so feasibility across different vendors should be validated. Also, although it is expected that our deep learning algorithm enables functional measurements of functional liver capacity, its actual clinical impact on patient care was not evaluated. To conclude, our deep learning algorithm enables the accurate measurement of the volume and signal intensity of the liver and spleen using gadoxetic acid-enhanced hepatobiliary phase of MRI, and it may be useful for assessing functional liver capacity. Thank you for listening, and I hope this video helps you understand our study.